Welcome to our conference session titled Living with PNH. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the program today. Immediately following the presentation, there will be a question and answer session. If you're participating online, please feel free to submit your questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit your questions or comments, type in your question in the Q&A box and hit enter. We'll do our best to get to everyone's questions today. And for those participating in person, we'll be passing around a microphone for your questions so those listening online will be able to hear the questions and then the response from Dr. Scott. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time if you're participating online. And for everyone, please do not share any private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Bart Scott. Dr. Scott is a professor of medicine, the Division of Oncology at the University of Washington, and a professor to the Clinic Research Division at the Fred Hutchinson Cancer Research Center. He earned an undergraduate degree at the University of Alabama, his medical degree at the University of Alabama Mobile and School of Medicine, completed his residency at Johns Hopkins, and his fellowship at the University of Washington Hematology Oncology. Thank you, Dr. Scott, for coming all the way from Seattle to join us today.
Thank you. It's my pleasure to be with you today. And it's a small group of people, so I hope it's very interactive and you guys think of some questions to ask me. So I'm here today to speak to you about a very rare disease, but also a disease with a lot of morbidity and risk of death, and it affects people in their mid-30s. So it can be devastating if you have it. And the other big thing about PNH is that it's difficult to diagnose. So it's not uncommon for people to go many, many years before they're finally told what it is they exactly have. And it affects almost every organ in your body. In regards to the name, PNH stands for paroxysmal nocturnal hemoglobinuria. But this is not a very good name because it doesn't really speak to the nature of the disease. And our understanding of PNH has improved over the years since it was first discovered, but it's actually not paroxysmal. The symptoms can be very severe, and when that severity can be paroxysmal, it can come and go. But it's always constant, always ongoing. Nocturnal, well, it's not just at night. Plenty of people have worsening hemolysis during the day. And then hemoglobinuria, which is the last part of the name, is actually only seen in about 25% of patients with PNH. So most people with PNH actually do not have hemoglobinuria. The underlying issue is these GPI anchor proteins, which you see in the blue dots here. These are very important proteins that bind other proteins to the surface of your cells and help to control different systems in your body. One of those systems is called the complement system. It's a part of your immune system. And the complement system, if you ever get a cut, if you ever fall, scrape your knee, immediately there's bacteria that get into your bloodstream, and the complement system is your first line of defense. It attacks those bacteria and helps to kill it. But it's not cellular-based, it's humoral-based, and it's not very intelligent. So what keeps it from attacking yourself? Well, these two proteins, CD55 and CD59, they regulate complement. And they're supposed to be bound to the surface of your cells. But in order to be bound to the surface of your cells, you need these GP anchor proteins. And the problem in PNH is that these GP anchor proteins are not functional or completely missing. So that your complement can no longer tell self from non-self, and your complement attacks your own cells. So in essence, PNH is essentially an autoimmune disease, but complement mediated. The mutation that can lead to this occurs in chromosome X. There's been about 40 different, more than 180 mutations in PIG-A have been reported in patients with PNH, and we're discovering new mutations all the time. So this is an acquired event. It's not something that you're born with, and having PNH yourself doesn't increase the risk of any of your children getting PNH. It's just something that happens to you. Historically, we classified PNH into 3 separate groups. Classical PNH, that's where you destroy your own red cells. We call that intravascular hemolysis. You make immature red cells. We call that reticulocytosis. LDH, lactate dehydrogenase, is an enzyme inside the red cells that's released when you destroy them. And then it can also be seen with another bone marrow disorder, which kind of brings us to today and explains why you're at an aplastic anemia MDS meeting, because PNH can frequently be seen with these disorders. And you can have both the bone marrow disorder and the intravascular hemolysis. That's the destruction of red cells. The last group here is what we call subclinical PNH, and that's PNH that's just detected but is not causing the patient any significant clinical problems. So it's our practice, and most major medical centers practice, to check your aplastic anemia patient to see if they have PNH, if they have a PNH clone. And sometimes it can be very, very low, a low PNH clone size, which we'll get into, and the patient doesn't have any symptoms from it. This is the historical survival curves that have been reported with PNH. This is before the approval of treatments, and we now have very good treatments, which we'll get into. The prevalence, though, as you see, is about 16 people per million, so it's a very rare disease, median age of 32. Historically, and this has changed, so I can just tell you the good news is that it's not as bad as it was, but historically the 5-year mortality rate was 35%. As I mentioned, there can be classical PNH, and then there can be PNH associated with a bone marrow failure disorder. And this can either be with aplastic anemia or with MDS. All of these diseases have low blood counts and have a propensity to progress to leukemia, including PNH. And if the PNH clone does progress to leukemia, it historically has had a very poor prognosis. So this is the normal circumstance where you have a PIG-A gene, it's being made, and here you have the GP anchor protein that you see on the cell wall, and you have CD55 and CD59 on the surface. Here you have a PNH cell, the PIG-A gene has been mutated, they're not making the GP anchor protein, and although CD55 and CD59 are being manufactured, they're not able to be placed on the cells. Why do you see PNH and aplastic anemia together? Well, one theory is that in some patients with aplastic anemia, they actually have T-cell attack on the GP anchor proteins itself. So in some patients with aplastic anemia, you have a cytotoxic T-cell. That's part of the immune system. It's part of the cellular-based immune system. It comes along and it starts killing some of the stem cells by attacking the GP anchor protein. But if you have a PNH mutation, that's selected for because it doesn't have the GP anchor protein. So the PNH clone is allowed to grow and expand in the setting of a cytotoxic T-cell attack. And that's one explanation for why you can see aplastic anemia and PNH together so commonly. Of course, this doesn't explain classical PNH. So what kind of selective advantage does the PNH clone have outside of this cytotoxic T-cell attack? And those are some of the studies that are being done to try to understand why in classical PNH there's this growth and survival advantage for the PNH clone. But we do know that in some patients with aplastic anemia, the GP anchor deficient cell has a selective growth survival advantage, and it can expand over time. And that's one of the reasons why it's so important to test your aplastic anemia patients for PNH, because even if it's a low level at the time of initial diagnosis, it can expand and grow over time. So as I mentioned to you, complement is the first part of your immune system. It's always turned on. It's a very powerful response. It's good that we have it. It's saved all of our lives more times than you can probably count. Complement can be activated for many different reasons, all of which you see here. Anything that can activate complement can make PNH worse. So if you are a patient with PNH and you get an infection, that can make your PNH worse. Elective surgery, pregnancy, any autoimmune disease, this can all make your PNH worse. The first part of complement is called the proximal complement, and it's the first part of the complement cascade, and there's this amplification loop that's built in. The second part of complement is called the terminal complement, and there's two main branches, C5a, which is a very potent anaphylatoxin. It's like the messenger of complement. It says, hey, we've got a bad infection here. It causes a lot of symptoms and problems like fever, myalgias, makes people feel like they have the flu. And this actually contributes more to the symptomatology of PNH than we have historically thought. So it's fair to say that PNH is not just a hemolytic disease, it's also an inflammatory disease. And a lot of the symptoms that PNH patients have and problems that they have is actually due to this increased production of C5a. On the other side, we have what's called a membrane attack complex. And this complement actually makes a hole in the wall of bacteria and kills the bacteria. That's how it functions. And then when the cells die, that's good because they're bacteria and you don't want them in your body. But obviously, if it's your own cells that are being attacked, that's not good. And in the case of red cells, they can be destroyed by this membrane attack complex that forms a hole in the wall of the red cell. That's why you have these natural inhibitors that are present on your own cells. You can think of it like flags saying, okay, this is the home team, don't attack us. And the problem in PNH is that you're missing the flag pole. You're making the flags, but you can't put it on the pole because you don't have the pole to plant on your own team. So as I said, the immune system is basically, the complement is basically attacking itself. And then this is a graphic representation of what actually happens, but the red cells are normal here, but you can see that once they lose the GP-anchor proteins, they're attacked by the complement, and that leads to anemia, that leads to increased production of free hemoglobin. Hemoglobin binds to nitric oxide, which is freely circulating in your plasma. Nitric oxide helps to relax your blood vessels. It's a smooth muscle relaxant. So when you lower your nitric oxide, your blood vessels clamp down. And the same thing happens with all the smooth muscles in the body of a patient with PNH. So they can get abdominal pain because their gut is kind of clamping down. They can get difficulty swallowing because their esophagus also gets really tight because they're not able to relax their smooth muscles like they should. And the reason why is because they have nitric oxide consumption driven by this release of hemoglobin. And that leads to a lot of the issues that PNH patients can have. Blood clots, which we call thrombosis, that's blood clots. That's the leading cause of death in patients with PNH. And PNH is a very prothrombotic state. So there's an increased risk of blood clots in patients with PNH. Historically, treatments were not good. We would give essentially steroids, prednisone, when patients would have PNH flares. Prednisone is an immune suppressant. It decreases the inflammation. It's an anti-inflammatory agent, but it has a lot of side effects. I see a lot of patients with PNH, some of them older, who've been treated with prednisone for a large portion of their life. And now they have joint replacements, hip replacements, knee replacements, issues with diabetes. They have increased risk of morbid obesity because of this. So a lot of clinical problems can result from giving steroids. Transplant can be curative, but there's a high mortality rate up front with stem cell transplant, and there's a risk of another disease called graft versus host disease, which can have a significant impact on quality of life. Transfusion support doesn't really help with the increased inflammation. So the majority of symptomatology in patients with PNH is actually not driven from the anemia, but from the increased production of C5a. And then trying to prevent blood clots if you give them anticoagulants, like something like warfarin, The problem is that the pathophysiology of thrombosis in PNH is not addressed by anticoagulants effectively, so it doesn't really reduce their risk of thrombosis significantly. And then if you try to give erythroid stimulating agents like EPO, Procrit, oftentimes this will increase the PNH clone size. It seems like the PNH clone has a preferential response to erythroid stimulating agents in comparison to the non-PNH cells. Thrombosis is the leading cause of death in PNH, and the reason why patients get blood clots is multifactorial, and that's why the anticoagulants don't work so good. But there is actually a direct attack on the platelets itself from the membrane attack complex. So you get all these little microparticles of platelets in the blood. So there's actually a mechanical attack on the platelets. It's a mechanical change in the platelets. And of course, anticoagulants isn't going to address that. So the best treatment to prevent thrombosis is actually to prevent activation of the terminal complement. And we do have those treatments available now. LDH, lactate dehydrogenase, is associated with a higher risk of blood clots. So if you have a high LDH, you're more likely to have a blood clot. LDH is a marker of how active the PNH is. So that's not actually very surprising at all. First ever ischemic strokes are much higher in a PNH population. And then if you do an age adjustment and compare it to patients of a similar age, there's an 8-fold increased risk of strokes in patients with PNH, which of course can have significant morbidity and mortality. If you do have a blood clot and you survive it, you're 15 times more likely to die with your PNH. This is historical data and doesn't reflect changes currently with the treatments that we have. The most common type of blood clots that patients get is called a DVT. That's the most common type of blood clot overall. And that's problematic because if a patient has a DVT, to people who treat these kinds of diseases, it's not necessarily like an alarm bell. It's like, oh yeah, you got a DVT. It's a very common type of blood clot. But there are certain blood clots that are more strongly linked to PNH, and that would be the hepatic portal vein thrombosis. If you see that, and there's a patient, we get consulted, we're going to be thinking, oh my gosh, this patient could have PNH, because PNH is more strongly associated with this hepatic portal vein thrombosis. But a DVT is very common. Wouldn't necessarily set off alarm bells to look for PNH. And many patients can have blood clots before they're diagnosed with their PNH. If you treat with anticoagulants, as I mentioned to you, it's not very effective in reducing the thrombosis rate. That's what this graph is showing. Even if you have a low transfusion burden with red cells, you're still at risk for blood clots. Even in patients with lower clone sizes, they're at risk for blood clots. The risk is less for sure, and we've known this. So basically, the higher your clone size is, the more likely you are to have a blood clot. So this is something that we would follow in patients. Say, for example, in a plastic anemia patient who we haven't yet started treatment, we might follow their clone size over time. And if we see it increasing, that would raise our concern that this patient could be at risk for a blood clot. Chronic kidney disease is the second leading cause of death. So when you destroy the red blood cells, the hemoglobin can actually deposit within the kidneys itself and lead to an interstitial nephritis. And that causes some problems with your kidneys. This, fortunately, can improve if you start patients on complement-mediated treatment. And this is the risk of chronic kidney disease and stage 1 to 2 kidney disease. But about 64% of PNH patients exhibit chronic kidney disease. Patients can have symptoms even if they have very low clone sizes. So that's something to keep in mind when you're following a PNH patient, or if you are a PNH patient yourself. This is one study that looked at PNH over time, showing that around 59% of patients who were positive with PNH at the beginning, these are aplastic anemia patients, stayed positive. About 28% of these patients had an expansion of their PNH clone over time. So that's why if you are an aplastic anemia patient who is PNH positive, you want to follow that over time because the PNH can actually get worse. The presence of a PNH clone with aplastic anemia has been associated with improved response rates to immunosuppressive therapy. And that's one of the very common treatments that we give for aplastic anemia patients. That would consist of HEG and another drug called eltrombopag and another drug called cyclosporin. We typically give this. And if we see a PNH clone, it does identify a patient who might be more likely to respond to that treatment. You also see PNH in MDS patients. This is just one study that showed that the incidence of PNH was around 17.16% in early stage MDS patients. There have been other studies that have looked at this as well, and there's been a wide range of the proportion of patients with MDS. Anywhere from 20% to 6% of patients with MDS can have a PNH clone. The three main groups of patients that we are concerned about for developing PNH are patients who have cytopenias that's unexplained, if they have any type of hemolysis, and then if they have blood clots, unexplained blood clots. That would be another group of patients that we would say, okay, maybe we should consider testing for PNH. And how do you do that? You send their blood specimens. So you don't have to do a marrow to diagnose PNH. You can do that on the peripheral blood. Many patients with PNH have had a marrow done to look to see if they have one of these bone marrow failure disorders. Frequently, the PNH clone doesn't respond as well to the normal stimulants, and so it's not uncommon for PNH patients to have blood counts that are low. And I don't just mean anemia. They can have low platelet counts, and they can have low white cell counts. But we do this flow cytometry report on the blood, and we look at red blood cells, and we look at their CD59 expression. Now, in the normal situation, which is what you see here, type 1 red cells should have normal CD59 expression. So this patient has no PNH clone present. This patient, however, has a complete absence of CD59. I can't really exactly read the number there, but it seems like it's something around 13.6% of the red cells have CD59 that's gone. So this would be indicative of a patient with PNH. And then this patient has partial cells that are absent with CD59 and then complete cells that are absent with CD59. This is the more typical type of flow cytometric report you would see. And basically you add up the type 2 and type 3 cells, and that gives you the clone size in the red cells. But you don't want to just look at the red cells, and that's because they're being destroyed, and so they don't accurately reflect what the clone size is. And so when I have discussions with other physicians and we talk about, a patient and we say what their clone size is, I automatically know they're not telling me the clone size in the red cells because that's not as relevant as the clone size in the granulocytes or monocytes. And the reason why we want to follow the clone size in those cells is because they're more constant. They're not affected by blood transfusions, and they're not affected by hemolysis. So this is an example of a patient who had PNH testing done. We call this FLAIR. That stands for fluorescently labeled arylysine, and it binds directly to the GPA anchor protein. And this is the GPI positive groups of cells. So these are the normal cells here in pink, but in blue are the cells that are missing the GPA anchor protein. And so this would refer to the PNH clone size. And you can see it's around 80% in the white cells and then around 34% in the red cells. So there is a discrepancy here between the red cell clone size and granulocyte clone size. I do try to follow my patients at least once a year. This is from the International Cytometric Society, so it's a flow cytometry group. So they recommend testing, but it is a flow cytometry group, so you do have to take that into account. But I do follow my patients with AA and with MDS who have PNH clones over time. So what do we give for treatment? Because I haven't really talked about that. The first approved treatment was a drug called eculizumab, also known as Soliris, and it's an antibody. It's a monoclonal antibody, and it binds to complement 5. So when it does that, it prevents the complement from activating. So it suppresses complement activation. It consists of a murine portion, that's mouse. So a portion from a mouse and then a portion from humans. This hinge part right here is what we call complement activating. Now, antibodies can activate complement. And that's an important thing to know if you have a PNH patient, because if you give them some type of antibody-based therapy, you should be aware that it could potentially worsen their PNH. But the eculizumab has been modified so that this FC portion, which stands for fixes complement, that's this hinge portion of the antibody, has actually been turned off. So you don't get complement activation with infusion of eculizumab, which is good because PNH is a complement disease, so you don't want to make it worse with the treatment. So this antibody does not activate complement. So it comes along and it blocks the terminal complement cascade. Important thing to remember, though, is that this proximal complement cascade is still going. So you haven't fixed that problem. You've only fixed the problem at the end, and we'll come back to that. There have been a lot of studies with eculizumab, and it has been documented to be efficacious. The standard dosing of eculizumab is 600 milligrams weekly for 4 weeks, and then 900 milligrams every other week, IV infusion. This can be delivered at home. For some of my patients, they're able to get them at home. We now have a longer acting antibody, but it was an issue for some of my patients who traveled, but we would work with the manufacturer to make sure they could get it when they were traveling. Because it inactivates terminal complement cascade, I should have mentioned that there's one bacteria in particular that we're concerned about, and that's Neisseria. So that's Neisseria meningococcus and gonococcus. And patients with PNH who are treated with this don't have the standard protection for that. So before we treat patients with eculizumab or really any complement-mediated therapy, we want to make sure that they're vaccinated if possible. Now, if somebody's got really horrible PNH and they come in with a stroke or a heart attack or a pulmonary embolus, I'm not going to wait 2 weeks after the vaccine to start treatment. I'm going to start treatment right away, but I'll give them prophylaxis with penicillin to help prevent the infection. This is data from the randomized trial called Triumph, and basically what you saw is that the LDH immediately goes down. And remember, LDH is a marker of hemolysis. And then this is the control arm, placebo group, and they're allowed to cross over, and you can see as soon as they crossed over and received active agent, their LDH went down as well. It also reduced blood clots, so lower risk of blood clots. It also reduced blood clots in people who were on anticoagulants, so it worked just as well in patients who were on blood thinners. It also improved kidney disease over time. So this is following patients over time. You can see that around 34% of patients treated with eculizumab had improvement in their kidney function over time. It also reduced transfusion need. So this is the overall response, and you can see that the patients not on ECU had a median of 10 units transfused, and that was all the way down to much less than 1 in the active treatment arm. So it lowers the LDH, lowers the risk of thrombosis, it improves the transfusion requirements, it also improves chronic kidney disease, and it makes you feel better. So they did what's called a FACIT fatigue score, and remember this was a double-blind placebo randomized control trial, so there was no real placebo effect because they controlled for that. And you can see that patients who received the eculizumab had improvement in their FACIT fatigue scores. They also improved some markers of what we call pulmonary hypertension, and that's basically a problem in your lungs where your blood pressure is too high, and it can cause patients with PNH to become short of breath. And you can see that the patients who were treated with the eculizumab, Soliris is the other name for that, had improvement in their blood pressure. Okay, so that's eculizumab. Now I'm going to talk to you about ravulizumab, which is Ultomiris. The important thing to know about ravulizumab is that it's essentially the same drug, except the antibody has been modified so that it recirculates, and it has a longer half-life. So what that means from a patient perspective is that you don't have to get the infusions as frequently. So it's more convenient from a patient perspective. There is no evidence to date that ravulizumab is more effective. So its benefit is in less frequent administration. There have been 2 trials. The naive trial randomized people up front to either Ultomiris or eculizumab. The switch trial took people on eculizumab and either kept them on eculizumab or switched them to Ultomiris. Both of these studies were what we call non-inferiority studies, and those essentially mean we don't have to show that it's better, we just have to show that it's about the same. And we do that in medicine when drugs are cheaper, more convenient, or safer. So when they are those things, we don't have to show it's better than whatever we standardly give, we just have to show it's not worse. And so this is the outline of how these studies were done. This is the naive and switch trials, and you can see that they were randomized to either receive ravulizumab or eculizumab, either up front or switching. If you were on the switch trial, you had to be on a stable dose of eculizumab for about 6 months. Both of these studies showed non-inferiority, so they met their endpoint, and the drug was approved for treatment of PNH. There is some indication that the C5 levels may be better controlled with ravulizumab in comparison to eculizumab. I mentioned to you that it's essentially the same drug, but ravulizumab, the way we dose it, is weight-based. So, in my opinion, the ability of ravulizumab to better control free C5 levels is more related to the correct dose being given, because it's a weight-based medication, whereas with eculizumab, we just got the same dose to everybody. You got 600 weekly for 4 weeks, and then you got 900 milligrams every other week. You don't have to be a doctor to know, wait a minute, giving the same dose, the same drug to everybody, that doesn't make sense, because we all know we're a little bit different. We metabolize drugs in a different way. So I really think that the ability of ravulizumab to better control C5 is more related just to the fact that we're given the correct dose. It's given it is given every 8 weeks, and when you do give it, you check a CBC, a reticulocyte count, and LDH. Okay, so this is some good news. This is a more recent study looking at survival in PNH, and this is a Soliris-treated population, basically showing that the survival is more similar to age and gender match controls in patients who are on anti-complement therapy. I mentioned to you that the proximal complement is still active and that we would come back to that. So C3b, remember, this is the proximal complement, the first part of complement, is activated in PNH. And it binds to this C3b, actually marks cells. It's a marker. It's basically your immune system planting a flag or a marker on cells that it wants to destroy. And when this cell comes through the spleen, it's destroyed. Now, you're supposed to be doing that to bacteria, so it's part of our normal immune process. But as I mentioned to you, the red cells are missing. In PNH, they're missing the complement control. So your complement thinks this red cell is a bacteria. And so it's marking it with C3b. And then when the red cell goes through the spleen, it's destroyed. This process is actually still occurring in the setting of eculizumab or ravulizumab, because this terminal complement is the only part that's being treated. So the proximal complement is still activated. So there are some patients, in my opinion, rarely, but there are some patients who still have issues, significant issues, after treatment with eculizumab or ravulizumab, and remain transfusion dependent because of this proximal complement. Now, we call this process extravascular hemolysis, which is distinguishable from intravascular hemolysis. But essentially, you're destroying your red cells, but in this case, not in the blood vessels itself, but in the spleen. And that leads me to the new kid on the block called pegcetacoplan, which is more recently approved to treat patients with PNH, but it blocks the first part of complement. So it can be effective in treating extravascular hemolysis. It was called Apellis 2. It's also known as Empaveli, but it's a pegylated peptide. It binds to C3 and it activates it. You can see that it's given twice weekly as a subcutaneous infusion. There is a risk of infection, so you need to make sure patients are appropriately vaccinated. And here we're blocking both the proximal and terminal complement. So you're really suppressing complement. So I have to tell you that there was a big concern about infectious risk with this agent. But at least with the published data so far, maybe we really worried too much about that because it doesn't appear to be as pro-infectious as we thought it might be. But it is important to vaccinate people if possible. There was a randomized trial comparing pegcetacoplan to eculizumab. There was a 4-week run-in where patients received both, and then they were randomized to either receive pegcetacoplan alone or eculizumab alone. It is important to remember that patients who enrolled into this trial must have received at least one transfusion within a year. So it was a select population of patients with PNH who were not adequately controlled with eculizumab. The primary endpoint of the study was change in baseline hemoglobin, and it did meet its primary endpoint. And you can see that with pegcetacoplan, the hemoglobin remained increased without transfusion support. And then this is the eculizumab arm. And remember, these were selected patients who were transfusion requiring at least once a year with PNH. So this is not all ECU-treated patients. I think that's important to remember. Skip this. Okay, so pegcetacoplan, ravulizumab, eculizumab, 3 FDA-approved treatments. We don't really transplant patients with PNH anymore, and the reason why is because there's a very big risk of upfront treatment-related mortality and thrombosis risk, but there are some exceptions to that. So this is looking at basically 3 different groups with PNH, recurrent hemolytic crisis. This is older data, okay? So this is kind of before the ECU era. But if you had hemolysis as the indication for PNH, you had the best survival. This is aplastic anemia, bone marrow failure, and this is thrombosis. If you had thrombosis as your need to transplant a patient, those patients did the worst. The 5-year overall survival is approximately 70% in patients who undergo transplant with PNH, but you can see that there is an increased mortality up front within the first year of about 20% historically. So that's one of the reasons why we don't transplant patients with PNH that much anymore. When would I transplant a patient with PNH? If they still had hemolysis, uncontrolled hemolysis, despite treatment with pegcetacoplan and complement inhibitors, if they had still recurrent thrombosis, those would be the 2 main reasons, or if they have a significant associated bone marrow failure disorder. So, for example, severe AA or MDS. There's a lot of different treatments that are currently in development, and everybody's very excited about this. And the most exciting things about these new treatments are that they're pills, oral pills that are being developed. So hopefully in the future, we'll be able to treat this disease with pills rather than with IV infusions, but these are just in early development. So in summary, PNH is a chronic life-threatening complement-mediated disease. Blood clots are the major cause of death. It is acquired, and it is associated with bone marrow failure disorders, MDS and aplastic anemia. There are 3 FDA-approved treatments for PNH, eculizumab, ravulizumab, and pegcetacoplan. No superiority studies for upfront treatment. So I can't say that one of these is better than another. And I will add with the caveat of pegcetacoplan, its randomized data are in a subset of patients with PNH treated with eculizumab who needed at least 1 red cell in a year. Oral agents, I forgot my T there, is in active development. Transplant is curative, but there's a high upfront mortality. LDH should be followed in your patients, in you. And extravascular hemolysis, that's EVH, is an important component of PNH. And so if you have a patient on eculizumab or ravulizumab who has continued symptoms and needs transfusion support, you should consider extravascular hemolysis as potentially causing this. Okay, and with that, I will stop. I have some backup slides about the meningitis vaccine, but they're pretty specific. So I have hopefully a lot of time for questions, so I'm happy to take any if you have any.
Thank you. Thank you so much, Dr. Scott. Do we have any questions in the audience right at the moment? Okay, so we have some on the line. Dr. Scott, this question is, with all of the new approved treatments, which is a good thing for PNH patients, how does a doctor decide which treatment to use?
Yes. Well, if you look at the approval, if you look at the data to support the use of pegcetacoplan, as I said many times, it is in a pretty select population. Pegcetacoplan is technically approved, actually, for PNH in general. So it's not specific for this group. Let me just get to the slide so I can point it out. For this group of patients. So if you look at the labeled indication, you could give pegcetacoplan up front, but I don't. And if other physicians do, I think that's fine. I really reserve it for what the randomized trial data shows. This is where the benefit was shown with this agent. That's not to say that that could change in the future, because there may be other clinical trials that come out showing pegcetacoplan is very effective up front, and if they do, then I would support that in a randomized fashion, of course. And then in regards to choosing between eculizumab and ravulizumab, in general, my preference is ravulizumab because it's better for patients in regards to the frequency of administration.
Thank you.
And I do support clinical trials, so there are a lot of clinical trials, so if you're a patient with PNH, you should not be worry over too much about going into a clinical trial, because we have a lot of regulatory bodies that monitor clinical studies, and we would not do a clinical trial if we thought it would harm you.
Thank you very
So
much.
going into
for
a
that.
clinical trial is also a very good option for upfront treatment.
Thank you. Any questions from the audience? Sure. Hang on 1 minute. Well, that way everybody can hear you online too. Sorry.
I know you said that nitric oxide can affect your swallowing.
Yes.
Can it also affect your vocal cords?
That's a good question. Potentially, I'll have to be honest with you. I can't recall if there's smooth muscle on our vocal cords or not. Is there? I don't know. Yeah. So, yeah, I would say that potentially could affect your voice.
Anyone else in the room here have a question at the moment? Okay. We have another question, Dr. Scott. Let me
Okay.
get over here. Okay. Our next one is, this is coming from an aplastic anemia patient who recently had a transplant. They were, at the onset of their diagnosis of aplastic anemia, also shown to have PNH clones. Does the transplant also cure the PNH, or is that something that they should be tested for ongoing?
The transplant should cure the PNH. The role of the goal of the transplant is to replace the stem cells with a new population of stem cells from a donor. So the answer to the question is yes. Transplant should cure both the marrow failure and the PNH, so you get 2 for 1.
Okay, thank you. Any questions from the room right now? Okay, our next question would be, this is coming from a patient who is still using Soliris, has not made this switch to Ultomiris. How easy is switching from Soliris to Ultomiris, and what should this patient expect?
Very easy. I've switched almost all my patients over. Basically, when you're due for your next dose of eculizumab, you give the loading dose of the ravulizumab, and then you give a maintenance dose 2 weeks later, and then after that maintenance dose, then you switch to every 8 weeks, so the next dose wouldn't be until 8 weeks later. It is weight-based. The infusion time may be a little bit longer, and there may be some issues if the patient's getting eculizumab at home and they want to do ravulizumab at home, so that's going to have to go through a reauthorization with the insurance company. I have had some patients who were getting ecu at home. When they switched, they had to come into the clinic to get the ravu, but it's only every 8 weeks, so it's still more convenient from the patient's perspective.
Thank you. Our next question says, this is coming from an aplastic anemia patient treated 8 months ago with ATG. Platelets are 114, normal neutrophils, hemoglobin has decreased to 8.7. Would this warranted a repeated flow cytometry to test for increased PNH clone size?
Well, difficult to say. And I think the best thing for me to do is to say, I don't know, because there's a lot of different things that we'd look at. So instead of addressing that particular issue, I'll address it in general, which is a question that frequently comes up when you're managing these patients. So you've got an aplastic anemia patient. They've received triple IST. They appear to have responded, and maybe they're on their cyclosporin, and they're going along, and something happens. And they come in. Their platelets are okay. Their white count's okay. So you're not immediately thinking, their aplastic anemia must have come back, but they're more anemic. And so what you would do is you would check an LDH. And if you see that the LDH is elevated, that's kind of a flashing signal to say, uh-oh, we better check that clone size again, because they could have developed intravascular hemolysis. So there's a lot of different issues that patients with aplastic anemia can develop while they're still on their immune suppression. And for example, cyclosporin itself can cause anemia and lowering of the red cell count. So you need to do that flow cytometric testing to check the clone size, because it could be the cyclosporin that's doing it. And then the other thing that you would want to look out for is the aplastic anemia itself coming back. So if you see pancytopenia, that would be more indicative of the AA coming back, and in that case, we would do a bone marrow. But to look for PNH, you would check an LDH, and if it's elevated, you would repeat the clone size.
Thank you. Any questions from the room? No? Oh, okay, hang on one second.
I'm just curious, with these treatments, if you say your clone size is like 98%, should you see your clone size go down throughout the course of your treatment?
Great
or does
question.
It stay
I'm
the
so
same?
glad you asked that. That's a question that I ask my fellows all the time. So I'm glad that you asked that. Let's see here. This is actually from one of my patients, so I'll put it on the board here. But this is the flow cytometry from one of my patients. This was at the time of diagnosis. And this is the FLAIR testing, fluorescent labeled aryl lysine on the monocytes, and the FLAIR testing on the neutrophils, and the CD59 testing on the erythrocytes. And you can see that the red cell clone size was 36%, granulocyte clone size 67%, monocyte clone size 78%. So why is the red cell clone size lower? Because you're destroying them and the patient is being transfused. If you put a patient on complement inhibitor, hopefully, if it's effective, they don't have significant extravascular hemolysis, they will not need to be transfused, and their LDH will become normal, and they will not be hemolyzing anymore. So if you do that, what do you think is going to happen to the red cell clone size? It's going to go up. So what actually happens when you give a patient eculizumab or ravulizumab is that the red cell clone size begins to approximate that of the neutrophils and the monocytes, because you're no longer destroying them. So I do ask that question to the fellows when we have a patient. I said, uh-oh, the red cell clone size is going up. What should we do? And they may say something like transplant them, and I said, no, actually, that means it's working. So that's what you want it to have happen.
Okay, thank you so much. This question is from an aplastic anemia patient who was actually diagnosed in the 80s. At the time, was first diagnosed with aplastic anemia, ATG, and was on steroids and cyclosporine for an extremely long time. Since being diagnosed with PNH, has not needed any form of treatment. However, their bone health is suffering from long-term uses of steroids. Is this something that you see common in other patients?
Yes. Yes. So I treat the bone marrow failure disorders. Allogeneic transplantation is a very common intervention for them. they're at risk for developing chronic GVHD, and when they do, they may require years of immunosuppressive treatment with steroid therapy and other immunosuppressants, and it does put them at long-term risk for bad outcomes, bone fractures, multiple fractures, things like that. So unfortunately, prednisone has a lot of side effects, and I think this patient is experiencing them.
Thank you so much. A question from the room? Okay, we'll go to our next one online. Do you foresee a future of treatment for PNH patients with oral medications?
Yes.
Okay.
That was part of the agents in development, and
Okay.
I think in the future, we'll probably be giving people pills as opposed to IV infusions.
Okay, great, thank you. Anything from the room before I go to one online? Okay, next question online is, this patient has done well on Ultramarys. It says for the little over a year. However, they're having some breakthrough hemolysis. There's talk about switching to pegcetacoplan. What are your thoughts? When should you wait to switch in your experience? And if they do switch, what is that process?
Okay. All right. So I'm going to address this question in general.
Yes.
You have a patient who's on complement inhibitor, and then they're not getting the type of response that you want. The first thing you need to figure out is why. One reason that they are not getting the response that you want is because they have ongoing intravascular hemolysis. And it's important to find that if that is the case. And so how do you do that? You check an LDH before their infusion of either ravulizumab or eculizumab, whichever one they're on. And if the LDH is elevated, then you have an issue with intravascular hemolysis that needs to be addressed. And switching to pegcetacoplan is not necessarily the best choice. So the first thing I would do is do a full history, do an exam, and what I'm looking for is any chronic infection. So I can tell you that I've had patients with chronic gingivitis, for instance, and that can cause a big problem with breakthrough intravascular hemolysis. So if they have some type of chronic infection, cholecystitis, recurrent choledocholithiasis, you want to look for these things that could be causing a flare. If you don't find anything that can't be treated, then you should work on trying to decrease the interval of the complement inhibitor or increasing the dose of the complement inhibitor. So that's how you would address intravascular hemolysis. Now, if the reason why they're having ongoing issues is because of extravascular hemolysis, then that is when you would consider switching to pegcetacoplan. And how do you know that? Well, you check the LDH, and in this case, the LDH is normal, but maybe their hemoglobin's 8 and they need to be transfused. And then you would do what's called a Coombs test. And technically, this is getting really complicated, but when you first diagnose a PNH patient, it's Coombs negative. But if you treat a patient with eculizumab, it becomes Coombs positive because they start putting C3b on the surface of their red cells, and you can test for that. So if you have a Coombs test that comes back positive for C3b, if they have a normal LDH, and they're still needing transfusion support, and they don't have aplastic anemia, and that's a big caveat because you need to consider that as well, because if they've got pancytopenia, you should be aware that PNH patients can get aplastic anemia just like aplastic anemia patients can get PNH. But providing all of that, then that's when I would consider switching and starting them on pegcetacoplan. It's a twice-a-week infusion. I keep it going until they get the pegcetacoplan started, and I would want their first infusion to occur, for example, if they're on ravulizumab, before 6 weeks after the dose of Ravu, so that there's some overlap. So I tried to timing the start of the pegcetacoplan to be within 6 weeks of the first dose of ravulizumab. And then if it's on eculizumab, I would want to do it before the 10 days.
Thank you. Any questions in the room? Okay. Our next question comes from a patient who has done well with the switch from Solaris to Ultramarys and is doing great. However, she is in the early stages of menopause. Anything this PNH patient needs to know with regards to treatment or how this may affect the disease?
Any stressor can increase complement levels and potentially increase the risk of breakthrough hemolysis, and that would include going through menopause. But other than that, not anything specific.
Okay, great, thank you. Any questions from in the room? Okay. And I'm not sure if you'll want to answer this. This was in regards to for children with PNH.
Okay, we can do it.
You want to try that one?
Sure.
Okay. First of all, how common is PNH in children? And they are aware that Ultramaris is approved for children. Any future of any other possibilities for treatment for kids?
Well, first, PNH is very rare. The median age of diagnosis is 32. It's even more rare in children, so it's uncommonly seen in them. Yes, there are treatments in development for children with PNH, just like there are for adults. So that's my answer to the question.
Thank you. Anyone else in the room? Okay. Our next question is regarding MDS and PNH. One, how common is this? And which of the diseases do you try to treat, the MDS or the PNH first?
Right. So there's different studies that have looked at this, but anywhere from 6 to 17% of MDS patients can have a PNH clone. When you do have PNH with bone marrow failure, it is unusual for the PNH to be the most pressing issue. Usually with aplastics or with MDS patients, the clone size that you find in them is low. So it's rare that you have a patient with AA or MDS that also has significant intravascular hemolysis. So in general, you treat the bone marrow failure first. However, there's exceptions to rules, and I have had patients myself that have come in with PE, for instance, who had aplastic anemia and PNH, and the clone size remarkably was quite high, around 80%. And that person, the most life-threatening issue was the pulmonary embolus, so I treated them for the PNH first. But what you do as the physician is that you see the patient, you diagnose them correctly, and you weigh the risks of each of these, and whichever one is the riskiest is the one that you treat first.
Thank you. This question is in regards to blood clots for PNH patient. What is the most common blood clot for PNH patients and why?
DVT. And that's the most common blood clot overall. The deep veins in your legs, for whatever reason, are the best places to form clots. It has to do with the physical mechanics of the way your blood flows. And those blood vessels are the ones that are most likely to have as rapid flow. So because of sitting, because of the way we do things as human beings, DVT by far is the most common blood clot seen in PNH patients.
And part 2 of this question is there a standard protocol for monitoring PNH patients for blood clots?
Is there a standard protocol for monitoring PNH patients for blood clots? No.
Okay.
Maybe there should be, but there's not.
Okay, thank you. Our next question is in regards to L-Traumapag. Has L-Traumapag ever been used in clinical trials or otherwise to see how PNH patients are affected?
Good question. I like to think that I know a lot about this disease, but I don't know everything. So when people ask me those kinds of questions, I always say, to my knowledge, because I don't want to say that, oh, maybe there's some article out there in some obscure journal that I've never seen. But to my knowledge, I haven't seen any data looking at L-Traumapag and what effect it has on PNH. I think that the reason the question might come up is because of a potential concern that the L-Traumapag could preferentially lead to a clonal expansion of the PNH. If that is the case, I've not heard about it. And aplastic anemia and PNH are commonly seen together, and I'm certain there's a lot of aplastic patients with low clone PNH have been exposed to L-Traumapag. And I've treated patients with low clone PNH with L-Traumapag, and I've not had a clonal expansion on El Trombopag yet. But that doesn't mean it's not out there.
Thank you. Anyone in the room have a question? Okay, we'll go to our next one online. It says, Dr. Scott, thank you for the amazing presentation. I'd like to know, sorry, hang on one second. I think we've got a two-part question here. Could you please review what the LDH is?
Lactate dehydrogenase. It's an isoenzyme, and there's seven different isomers that have been reported that are known. And there's two isomers that are found within red cells. And so when you destroy them, that enzyme is released into the blood. So the LDH is elevated in PNH patients when they destroy their red cells. So it's a marker of intravascular hemolysis.
Thank you.
There are other reasons why your LDH can be elevated. Myelofibrosis patients have high LDHs because of bone involvement. Liver, lung, heart. Used to be before troponin, way back when, I'm old, but we used to actually follow LDH after heart attacks because that was also elevated in heart attacks, MIs. Now we have a better enzyme called troponin that we follow.
Any questions from inside the room? Okay. Our next question is, if an aplastic anemia patient has suffered from side effects from cyclosporine, can basically gum gingeritis, can the side effects increase intravascular issues and increase the PNH clone size?
No. No. There are, gingival swelling is a very common side effect of cyclosporine. And there are specific treatments that can be given. So I would encourage this patient, if they haven't already, to discuss that complication with their physician.
Great. Thank you. Any questions from the room? Okay. This comes from a newly diagnosed PNH patient who has their first appointment with their PNH expert in 2 weeks. They'd like to know, Dr. Scott, what questions would you recommend that I ask my PNH expert?
Do I need treatment? Which treatment would you recommend? What is my clone size? Am I at risk for blood clots? Those are the questions that immediately come to mind.
Great, thank you. Second part to this is, if they're going to be using treatment and they understand they'll have to be vaccinated for meningitis, is that a one-time vaccine or are you revaccinated throughout your life of treatment?
You have to
Thank
be
you.
revaccinated. So this was the slide on the meningitis vaccines. But you would want to give the Menveo, that's what we give, and then you repeat it approximately every 5 years, as you can see on this slide. You give a booster. And you also want to make sure that you also do the Bexsero, which is meningitis B. So you want to do the regular meningitis vaccine and then also the Bexsero vaccine. You get 2 doses of that, and you also repeat that approximately every 3 years.
Any other questions from the room? Okay, that was all of our questions online. So thank you so much, Dr. Scott, for sharing your time and your expertise and traveling all the way from Seattle to join us here today. Thank you so much.
Thank you for having me. It's great to be here. Thank you.
If you'd like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing this session, clicking on replay, or by navigating the on-demand tab in the platform hub. If you have any additional questions, feel free to send it to us at any time within 3 ways. Send an email to help@aands.org, call our helpline at 800-747-2820, or submit your question on our Facebook page. If you're watching online, please do take a few minutes to complete the online survey. Your responses help us with planning our future programming. Please be sure, if you're online, to visit our exhibit hall and chat with our sponsors. Also, we're getting ready to head off to lunch. So if you're watching online, there is the ability for you to have lunch and chat with others using the discussion option, which is underneath of the community tab. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank all of you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our session.